Hello, everyone. Welcome to the Cancer Doctor podcast. I am your host, Roebrt Dr. And today we have the pleasure of meeting with Dr. Frank Shallenberger. Dr. Frank Shallenberger is a medical doctor. He's also licensed in homeopathic medicine, and he is certified with the American Board of Anti-Aging for Medicine. Dr. Shallenberger has been practicing medicine since 1973, so quite a long time. He's a pioneer in the alternative integrative field of medicine since about 1978. And I think Dr. Shallenberger is maybe one of maybe 16 or less than 20 physicians in the state of Nevada that are licensed in conventional medicine in addition to homeopathic medicine. So it makes him a little bit unique in that respect. And that approach, I think, allows him to get some results that other medical doctors would not be able to achieve, which is one of the reasons I wanted to have him on this podcast. Also, the center that he heads up is called the Nevada Center for Alternative Anti-Aging and Medicine. Now, you may be wondering why we're having the conversation with them as it relates to cancer. Well, that's because he ends up treating patients that have cancer. Because Dr. Shallenberger specializes in anti-aging and disease prevention, by default, he ends up seeing patients that have cancer as well. And he has protocols for those type of patients also, which I think some of you may have heard of before, and others of you, it'll be the first time. But I'm sure that we're going to get into some of the little variances in his practice and why he does what he does and in that method behind it. Additionally, if you want to find him, the website is antiagingmedicine.com. Antiagingmedicine.com. You can also find them on cancerdoctor.com. They do have the seal of approval of Verified Plus on our web pages, and they are in Carson City, Nevada, and their telephone number is 775-884-3990. I like to get that information out at the very top because people will be wondering about it, so write it down. Dr. Shallenberger, thank you so much for joining us. It is an absolute pleasure to have you here with us today.
I'm glad I'm with you, Robert. Thanks for having me.
Dr. Shallenberger, I got a question for you that's important because you have a lot of experience under your belt now. So I consider this a real treat. In your field of practice, what are some of the most significant changes or evolutions that you have seen occur in the field of medicine that have hurt us, but also helped us as well?
Well, okay. This whole thing is a journey. We could look at it that way. You start off with one thing like I did in 1973. I graduated and, headed on out on my journey. And I thought I was supposed to go over here, but it turns out, nope, I'm ending up over there. Anyhow, there's all kinds of advances we could speak of. I would have to say the biggest advances I've seen is in surgery and in emergency medicine. It's just huge advances. So I think everybody appreciates that. We can save people now that were absolutely unsavable back when I graduated from medical school. So just keeping up with that level of technology has been both fun but challenging at the same time. So the technology, the MRI scans, the testing, it's just dramatic what we can do now, even compared to 5 years ago, with all kinds of diseases. In terms of the homeopathic end, hasn't changed that much. The whole homeopathic thing was started, like 150 years ago, maybe 160 years ago. And it really hasn't changed a lot. We're learning more things, say, about herbs. We're learning some things, more and more about ozone therapy and such. But these things were around 150 years ago. They, to a large extent, were starting to get suppressed around the 1930s. So a lot of it's resurrected. But it's really fascinating. So the conventional medicine thing has dramatically improved in the areas of surgery and emergency medicine, and the homeopathic therapy has always been good, And we still do. I still pretty close do the same thing homeopathically now as I did 30 years ago.
What what drove you as a medical doctor in your early years to investigate homeopathic medicine? Because when I think of homeopathic, you mentioned herbs a minute ago. I'm thinking like, okay, plants, weeds, what is this, right? It sounds kind of, woo-woo to some people. What drove you to look into this? Why was this a legitimate field of practice for you?
Well, I could talk a lot about that, but I'll try and just kind of summarize it briefly and say, I got out of medical school. I went into emergency medicine. I worked there for about 7 to 8 years, loved it. People would come into the emergency room with some kind of bad problem, a broken leg, some other kind of injury, things like that. We would go right in there, determine the cause of the problem, fix the problem, and off they'd go. And I thought, this is very satisfying for me. Patients have a problem. I am able to diagnose and treat them, fix that problem. They no longer have the problem, and bingo, that was really cool.
Mhm.
Well, after a while, for some political reasons and other issues, I decided to get out of emergency medicine and just kind of go into general medicine. You could call it internal medicine, you could call it family medicine, whatever, but general sorts of medicine. And I was in this, Robert, for 6 months before I realized, boy, this is different than emergency medicine. These guys are not trying to find the cause of the injury. They are not trying to fix the injury. They are only dealing with symptomatic improvement. And I make this sort of humorous analogy that if I practiced medicine in the emergency room the way we now currently practice conventional medicine, you would come into my emergency room with a knife in your back, and I would give you an antidepressant and send you home. Because that's what they do now. They treat the symptom, but they don't actually look for the cause and repair the cause. And because of that, that's why in the late 1970s, I said, there's got to be another way. There's got to be something they didn't teach me in medical school, because this is silly, just to go around and dishing out drugs to treat symptoms. And by the way, I'm not knocking that. I have no problem with treating symptoms. But when you treat symptoms, and we could talk about cancer, you need to treat the cause of those symptoms, not just the symptoms, and then things get better. And that's how I got into it.
It sounds like you fell into it in a very, by accident. I love the analogy, by the way. I'll be borrowing that if you don't mind. So, when did you then begin to see cancer patients
Mhm.
more? How did that evolve? How did that happen overall?
Yeah, and that too is part of the journey. So several decades ago, I found myself in the course of my everyday practice, my patients would come in and say, "Oh yeah, I've got cancer. I'm seeing the oncologist over here, and can you help me at all? Can you make things better?" And I said, "Okay, I'm going to work with you while you're working with the oncologist, and we'll see what we can do." And it became really obvious to me after a while. Uh, Boy, the oncology, and even today, this is true. They do a great job at what they do, but they're very myopic. They here's the picture, here's the part they treat. Very myopic. And in the context of treating this little myopathy, the results are not that good, and there's a heck of a lot of toxicity created. So I thought, I'm going to try and help these patients treat cancer. And boy, that's a whole learning curve. So it took me years to learn and dig into this. What can I do to help patients with cancer? And it really wasn't until, and I tried all kinds of stuff, by the way, but it wasn't until I would say like 2 decades ago that I learned about insulin potentiation therapy that was the game changer for me. Now I have a very powerful tool that is actually every bit as good as the oncologist. So now my patients don't need to see an oncologist. They might want to for insurance reasons, but they don't need to see an oncologist because I can now do with insulin potentiation therapy what the oncologist can do, and just as well, but in a way, and we could talk a little bit about this, but in a way that's safer and has way few side effects. And at the same time, since the patient's getting the treatment from me, at the same time, I can put on all this stuff I know about homeopathic medicine. And instead of having that nice little myopic thing that they're going to get from their oncologist, now we got this. Now we can look at the cause of the cancer. We can look at the cause of the symptoms, and we can treat the cancer in a safer way and just as effective way. And by integrating all of this, because that would be the key. If when I have a patient talk to me, I say, I don't care if you see me or not. That's your business. I think I can do a pretty good job, but that's okay. You want to go see somebody else, I'm fine. But just make sure that if you're seeing an oncologist, at the same time, you're seeing somebody that is well-versed in alternative management. So that instead of just doing this little therapy, now you have the best of both worlds. So please, that would be a major thing for people out there. If you don't want to see me, that's fine. But make sure that you're getting not just the conventional approach, which is radiation, surgery, and chemo, but that you're getting that combined with detoxification, immune enhancement, other ways to optimize the radiation, surgery, and chemo, other ways to treat causes instead of just treat symptoms. Just make sure you do that, get the best of both worlds. That's the biggest advice I could give to anybody that is facing, fighting cancer.
Why is it that, if I call it alternative medicine or complementary medicine, why is it that it seems that physicians like yourself are able to take care of a problem at a root level much more so than conventional medicine? Why? Why is that happening?
That's the question. Why go see somebody that does things like I do versus just go see your standard oncologist? It's really comes down to what I was just saying. It's because we have a lot more tools in our chest. I mean, they only have the chemo, the radiation, and the surgery. That is it. They don't know about diet. They don't know about stress. They don't know about heavy metals. They don't know about microbiomes. They don't know about how to repair those things. They do never. You will never. Well, maybe there'd be some exceptions to this, but they're rare. You will never find an oncologist be able to tell you why you got the cancer. Why did you get the cancer? Now, if they don't know what caused your cancer, guess what? It's coming back. And that's the problem with cancer, conventional cancer management in the United States here, is it comes back. Despite all the, quote, advances that we've made in the conventional management of cancer, the 5-year survival rate for patients with stage 4 cancer remains a pathetic 3.5%, period. It was 3.5% back in the 1970s. It's still 3.5%. Why? Because the cancer comes back and they're not treating the cause. If you don't treat the cause of something, it keeps coming back.
Okay, got it. So what I hear you saying is, what you're not saying is you're not telling a patient don't get chemo or don't get radiation or don't get the surgery, but when you get those things, you better get these other complementary procedures done or medicines done that are going to shore up your immune system and help make those therapies more effective and protect you along the way so that outcomes by this quality of life, length of years, etc., ends up getting stacked in the patient's favor. Am I correct?
Yeah. And this really I treat a lot of things besides cancer. This isn't a principle that's unique to cancer. I don't care if you got an autoimmune disease, a chronic infection, whatever the heck you're dealing with. You better be not just getting the conventional management. You better be looking into practitioners who can get down to a causal level, who can talk to you about things that I just mentioned, like detoxification, immune enhancement, et cetera, and work both those things at the same time. Get the best of both worlds, because they are two different worlds. They're 100% two different worlds. My oncologist colleagues know absolutely nothing about diet. I don't mean a little bit, I mean zero. They don't know anything about herbs, vitamins, detoxification, nothing. So, but they know what they know real good.
Sure.
So I'm okay with that. I wish they'd learn how to use the low dose insulin method, because it's a lot less toxic. But leaving that aside, what they do, they're pretty darn good at it. They study it and they're good at it, but it's not enough.
Okay. So just a repeat again for our audience that's listening to this, what you just said, this even applies to other conditions outside of cancer, regardless of
Yeah.
your diagnosis, whatever you might get, God forbid. But if you do, you want to incorporate these other natural or alternative, you want to integrate these things into your conventional protocol that you might be receiving, because you're going to fare better overall. We're going to touch on IPT in a second, but something you just said, you've said it more than once, is diet. Why is what we put in our mouth and swallow or drink, why is that so vital to health and wellness? I know people have heard different answers, but your experience, why is it so crucial?
You know, there's a lot of ways to answer that question. Some of them can get complex and long-winded. I would say, on the one hand, it's pretty intuitively obvious what you put into your body is going to have an effect on your health. That, I think, that's not shocking news to people. Maybe the differences would be arguing over what's the best thing to put in your body, but it's pretty clear that if you're putting the wrong thing in your body, toxic substances in your body, you're smoking, if you're, eating poisonous substances, eating toxic water, drinking toxic water, all those things are going to be bad for you. So we can get into that. But here's another part of that answer. And that is that 4 years ago, 2 Canadian physicians published a fascinating study. And what it was a historical study. They went all the way back to 1880 and reviewed all the medical literature from 1880 up to the current present time. And they were looking specifically at reports on 3 diseases. One was macular degeneration, which, as most people now know, is the #1 cause of blindness here in the United States, macular degeneration. What's the history of that? They were looking at age-related Alzheimer's, which is, very common these days and becoming more common. And they were looking at heart attacks. Those 3 things. Amazingly, what they discovered was, up until 1920, those diseases were never reported. Period. There is no information they could find published in the medical literature prior to 1920, even indicating those diseases existed. So people understand this. Prior to 1920, no heart attacks, no age-related macular degeneration, and no age-related Alzheimer's. Didn't exist. What the heck happened in 1920? So the researchers looked at that, and the conclusion they came to had to do with what we eat. I could add to that, and I could say, yeah, that's when we started dishing drugs out left and right. That's when we started dishing out vaccines left and right. That's when the industrial area came along. We started polluting every dang thing we eat, breathe, or whatever. That's when we started getting completely stressed out over all kinds of things. So there's lots of electric lights. That's when people started staying up all night long. And we know that when you don't get your proper sleep in a circadian rhythm, you're more apt to get cancer, for example. So we know these things, but things turned to heck in 1920, and the biggest thing turned to heck was the way we eat. So it's pretty obvious to anybody that looks and thinks of this and looks at the data that our diets are to a large extent responsible for all the diseases we're getting now.
What about I totally agree with what you're saying. Uh, what about feeding schedules? Like, do we just eat too much? Is that a problem? Some people eat 3 meals a day. Some people I hear eat 6 small meals a day. I mean, does this also play a role?
It's really so fascinating. So yes, we do here in the United States. We eat way too much, and I don't care if you're skinny or fat. I'm not alluding to that. I'm skinny, but I guarantee you, folks, I can eat way too much. The food is plentiful. It's sitting right out there in front of me. I got a big old bowl of spaghetti or whatever it is that I got. I'll eat that and I'll start feeling full, and I'm saying, oh, this is pretty good. Let's eat some more. And I don't need to do that. The other thing that I don't need to do is I don't need to eat 3 meals a day. I mean, I absolutely don't need to eat 3 meals a day. And what we know is that cancer cells cannot function in people who are fasting. Now, that has to do with a system called the mTOR system. But when we're fasting, we downregulate this mTOR system that is partially responsible for why we get cancer in the first place. And I could tell patients some fabulous stories about how just not eating can cure cancer. Not eating. So in order to prevent recurrences of cancer in my patients, let's say they've got a cancer and we figure out a way to put them in remission from that. A lot of what I'm going to talk to them about is not eating. It's what you're going to eat, but a whole lot of it is not eating, so that we can harness that ability to downregulate mTOR and prevent the recurrences.
For those listening to this and never heard the term mTOR, what is that? Why does that matter?
So mTOR refers to a particular enzyme that can be activated. It's a transcription factor, technically a genetic transcription factor that can be activated in human beings. And there's a lot of issues around the activation mTOR. There's a lot of therapies that attack mTOR, by the way, cancer therapies that attack mTOR. But mTOR, when it is activated, tends to promote cancer development and cancer progression. So one of our goals is to downregulate the activity of mTOR. So again, it's a transcription factor, genetic transcription factor. We want to downregulate that. And one of the ways to do that is with herbs. Certain herbs like curcumin are known to downregulate mTOR. And the other thing that's known to downregulate it is fasting. And I'm thinking more like intermittent fasting. I'm also thinking, by the way, about ketogenic type of fasting will tend to downregulate mTOR.
Thank you for that. Well, I want to follow up also on your comments about IPT. So you are someone that you said you started doing this about 20 years ago, and it really changed your practice. For the person hearing that term for the first time in layman terms, what is IPT? What does that acronym stand for? And what makes it different than conventional chemotherapy?
So it stands for insulin potentiation therapy. And what that refers to is that we use the same chemotherapy drugs that the oncologists use. But the problem with conventional oncology is that when they give you that chemotherapy drug, they're going to inject that drug into your system. It's not going to just go to cancer cells. It goes to your healthy cells. And the problem is, in that system, it doesn't even preferentially go to cancer cells. Your healthy cells get the exact same dose of chemo that your cancer cells get. Now, the way it kind of works is that healthy cells don't die from that dose, whereas the cancer cells can't resist that dose and they'll die. But still, in all, your healthy cells get knocked out big time. You get diarrhea, you get nausea, you can get other cancers, you can have all kinds of side effects from the chemotherapy because you're getting the same amount of the drug in your healthy cells that you're getting in your cancer cells. And because of that, they have to give a much higher dose in order to get the dose in the cancer cells they want. But so what if there was a way to give somebody chemo and then direct that chemo preferentially into cancer cells? So not so much getting the healthy cells, most of it, or a lot of it at least, gets in the cancer cell. And that way that we know of now is called insulin potentiation therapy. We use the hormone insulin, and we could talk a little bit about why that works if you want to get into it.
Yes,
But
please.
cancer cells need insulin, and they need glucose and insulin are regulated together. So we use this principle such that when I inject chemo into the patient, I inject insulin at the same time and subsequently inject some sugar. And the reality of all of that is two things that happen with this that don't happen with conventional oncology. One thing is that more of the chemotherapy, significantly more, gets into the cancer cell than in the healthy cell. So that's good. The other thing is that this insulin upregulates the growth cycle of cancer cells. Now, if there's somebody that's hearing me right now, they might be thinking, now, wait a second. I've got cancer. Do I want to upregulate the way it's growing? And the answer is yes, you do when you're getting chemo. Because cancer cells are like all cells. They go through a number of stages, but they'll go to two resting stages in their life cycle. Okay, during that resting stage, they're not doing anything. They're just sitting there, kind of hibernating. All cells are like this, but cancer cells too. Now, when they're hibernating, guess what? They don't take up the chemo. So, at any one time, when I give a patient chemotherapy, or an oncologist gives them chemotherapy at any one time, I'm not going to kill all the cells. I'm only going to kill the cells that aren't in that resting phase. So I've got to wait for a while, and that's why you got to keep getting the chemo over and over and over again. So you wait for the cells in the resting phase to come out of that phase where they're now susceptible to the chemo, and then you give them chemo again. You got to keep doing it over and over. Well, here's the cool thing. When I put in insulin, guess what? It pushes those cells out of the resting phase. It gets them out of the resting phase. So I get more chemo in the cell. I get more killing activity because more of them are out of the resting phase. Not all of them, but more of them. And I get way less toxicity because I'm using much lower doses. And I get the same kill rate, if not better, than the chemo. It's when you stop and think of the advantages of this IPT, it's just a darn shame that it has not been FDA approved, and it's just not well utilized except for a few of us around the world.
So if I'm understanding this correctly, cancer cells, which are a fast dividing cell, but like other healthy cells, they go dormant, hibernation. So chemotherapy can't kill them in that state, but the insulin's going to force them out of their hibernation, as it were, to start dividing up again. And that's where the chemotherapy can do its work at that point. You mentioned glucose, that you utilize glucose as well. Where does that come in? Is that before the insulin and the chemo, or is it after? How does that work?
Different doctors will do this in different ways.
Okay.
The classic way that was developed by a Mexican doctor by the name of Perez Garcia back in the 50s. That's when all this thing came about, by the way. This is not a new guy on the block. It's been around for 60, 70 years. We've gotten better at it, of course, but this therapy has been around a long, long time. So what people can understand is that cancer cells are not normal cells. They are not healthy cells. They are not normal cells. They cannot protect themselves the way normal cells do, which is why that's their vulnerability. One of their vulnerabilities is, unlike healthy cells, they can't feed off fat molecules. There's some exceptions to this, I'll grant you, but by and large, this is true. Cancer cells cannot feed effectively off fat like healthy cells can. They only can feed effectively off glucose, sugar, and coming from carbohydrates, for example. And so that, and then the other thing about cancer cells that I want to put out there too, Robert, is that because cancer cells are unhealthy, they're not healthy cells, the only way they can survive is by growing. What people don't understand is, and we could talk a little bit about this because this topic is fascinating. The problem with the cancer, having cancer, is not that you have cancer. The fact that you have cancer tumor in your body is not the problem. The problem is you can't stop it from growing, and it's going to continue to grow. It doesn't have the growth restraints that healthy cells have. It has to continue to grow and grow and grow. And eventually, it's going to create a problem. It's either going to create a problem because it's expanding so large into, say, an organ or a blood vessel, or it's going to create a problem because it's going to start spreading throughout the body. But people need to understand, we don't technically have to get cancer out of your body. And there's some nuances to this. We don't have to get the cancer. We just have to stop it from growing. That's what we have to do. So when you stop and think about that, you ask, well, what do cancer cells need to grow? Folks, cancer cells need carbohydrate and they need insulin to grow. And we utilize those concepts. So since they need the sugar that they get from carbohydrate, and since they need the insulin, we give them the sugar and the insulin, and that spurts their growth rate, makes them vulnerable to the chemo, and at the same time, we give them the chemo, and the chemo gets carried in with the sugar into their cells, kind of like a Trojan horse sort of effect. They want that sugar. So they're opening up all their cell membranes to pull in that sugar. I just gave them the insulin, so they're going to pull in that sugar. And when they pull in the sugar, they're going to pull in the chemo agents as well. And we can selectively get more stuff into that cancer cells using this technique.
The context of this part of our discussion has been solid tumors. Would it be just as effective for blood cancers or sarcomas, or could it, or is this something that's better utilized for solid tumor type disease?
Yeah, I think you're right. And I will say that with certain of the liquid tumors, the lymphomas perhaps, and the leukemias, and to some extent the multiple myelomas, to those type of tumors, I'm not against patients seeing conventional chemo oncologists for that, because that's one area in conventional oncology that they're very progressed on, and they now can look at the genetics of some of these liquid tumors, and based upon the genetics come up with remedies that can be extremely effective. Now they're going to fail sometimes, like everything fails, and so I will see a patient that has a lymphoma or a leukemia or a multiple myeloma that's failed the conventional approach. But normally, if I have a patient that calls me up about that, I'm going to say, go see your oncologist, do what your oncologist says. And what I'm going to do is I'm going to hold your hand and make sure we cover all the other bases that your oncologist isn't going to cover. But most of the stuff, most of the time I deal with things, it is those solid tumors.
Is IPT more effective for an early stage solid tumor, a stage 1, or is it good for all stages, including 4? I know context is everything with this type of these type of conditions. What is your thought? What have you seen?
Yeah, in cancer, it's very similar to neurological diseases like Alzheimer's and such.
Mhm.
Don't wait too long.
Okay.
Don't wait too long. You will get to the point where there will be no cure. Now, one of those things, and if you're a patient out there listening to me and you have been diagnosed with what's called a stage 4 type of condition, there's no cure for you. Okay? There's no cure. I can't cure you. My conventional guys can't cure you. Outside of a miracle from God above, you are not going to get cured from that disease, i.e., don't have it anymore. What we can effectively do is stop it from growing so that you don't even know you have it. You're walking around, you're having a life. Yeah, you got to pay attention to what you eat. You do have to take certain things. That could be herbs, it could be medications. You're going to have to do certain things, okay, to stop the growth of the cancer. But we can do a lot to keep you alive a lot longer. Like I said, my conventional colleagues, there's 5-year success rate with the stage 4 is 3.5%. It's the same as it was 50 years ago.
And that 3.4 is, I'm assuming, for a 5-year.
for a 5-year survival. Yeah.
Survival rate. Okay. Okay. This is good. So here's my next question. And again, just thinking about solid tumors, because I'm thinking about IPT being better for solid tumor and even early cases. But some of these solid tumors, the oncologist ends up wanting to, well, let's not do chemo, let's do radiation. I'm thinking, let's say a male with prostate disease. They may remove the prostate followed by radiation, or maybe radiation before removing a prostate. Why do they opt to do radiation versus chemo? And then, so that's one question. The other question is, in the case that I'm bringing up with a prostate condition, would IPT be effective or something like that?
Okay, I'm glad you brought that up because prostate cancer, by and large, is so treatable even without surgery, without chemo, without radiation. It's, I hate to even use the word cancer when it comes to prostate cancer, because normally when you think of cancer, you think of something that's going to be difficult to deal with. Prostate cancer, for the most part, there are going to be some exceptions, but I would say 90% of the time is a piece of cake. We can treat that simply with diet, maybe some herbs, maybe fiddling around with your hormones a little bit. I really rarely find the need to get into things like radiation, surgery, anything else like that for prostate cancer, because by and large, it's so easily treated with benign things. It's just not the same kind of concept as you hear when you have other kinds of cancers, which of course can be a lot more dangerous. And this whole thing with prostate cancer, I swear, and I don't necessarily have the statistics to back me up on this, but I got a lot of experience. I think the way our conventional colleagues treat prostate cancer kills more prostate cancer patients than the actual disease. And I won't say that for other cancers, but I will say that for prostate cancer. The conventional management of prostate cancer with biopsies and with radiation and with surgery, the way they do it, not that those things, there's no place for those things, but the way they do it, that is just not keeping up with the technology that we have today.
So many men get frightened by the PSA test to come up. They're pushed or encouraged to do this PSA, and if it's elevated after removing the prostate, we have a problem. Or if it's just elevated in general at any time, we have a problem. And didn't mean to get on this subject, but just the nature of the discussion. But what is your professional response to that comment? PSA is everything.
Well, I think the PSA, there's a lot of misunderstanding around it. Prostate cells make PSA. Okay. That's why women don't have PSA levels. Men have PSA levels. There's supposed to be a normal PSA level. How they got to that, I'm not quite sure. But so prostate cells make PSA. Cancers, since they're growing more rapidly, make more PSA. I mean, that's a no-brainer. You can figure that out real quick. So again, all we want to do is arrest cancer growth. We're not necessarily looking to get rid of the cancer. We just want to stop the growth. Okay. So one way we can know that we're stopping the growth is we see the PSA go down, or we see the PSA at least level off. So if you have a PSA level, say, let's say over 15, somewhere between 15 up around 20, odds are pretty darn good you've got a cancer. There may be some reasons that there's a condition called prostatitis. There are some other reasons why somebody might have a PSA at that level and not have cancer, but that's going to be fairly uncommon. On the other hand, if you have a PSA below 15, you very likely may not have prostate cancer. Now, how do we know what you have? We know by looking at a couple of things. One way is what we call PSA velocity. That's the term used in the literature. PSA velocity means that the PSA is going to steadily go up. It's going to trend up over time. If it's trending straight over time, and by the way, I don't care if it's 1,000 or 30. I don't really care what the absolute number is. That's what people don't understand is they think the absolute number is some big deal. It's not a big deal. It's the trend over time that's the big deal. I have guys that came in to see me 15 years ago with a PSA in the thousands. They still have PSA in the thousands, and they're walking around, talking, have a life, doing anything they want to do, and you would never guess they had cancer. Why? Because we've stopped it from going up. We've stopped the growth of the cancer, and they're getting around just fine. So that's pretty much the key to this kind of thing, and prostate cancers are so amenable to that. The other reason why you don't need a biopsy is we've got MRIs of prostates now. Why in the heck do you want to have somebody go stick 20 needles into your prostate and run a 30 to 40% potential of missing the cancer? Now, I know they're getting better at it. So if somebody's listening to me and say, well, my doc said he can use an MRI to find the cancer, I got that. But you technically don't really even need a biopsy to diagnose prostate cancer.
So is the value of these PSA tests kind of like on par with the value of mammograms for breast disease, breast cancer?
No, mammograms are just horrible, and that's a whole nother deal.
So,
If you
so that's a worse test than a PSA test.
It's horrible. So let me just say, if you've got a cancer in your breast, do you want to go and compress it? Would you like to take that cancer and squeeze it with 40 pounds of weight?
No,
not unless you're an idiot. Because you know darn well when you squeeze that cancer, the propensity for causing metastases and spread to the local tissues is bang right there. So when you look at 3 large international studies, and I can get into the details, but I won't right now. But if you look at these 3 studies in countries that offer free mammograms versus countries that don't offer free mammograms, unbelievably, in 3 international studies, everyone says the same thing. The death rate from breast cancer in the countries with the free mammograms is significantly higher than the death rate from breast cancer in the countries that don't have free mammograms. Why? Because you're going to take people with the breast cancer and you're going to compress it. Now, add that to the fact that these routine mammograms are like horrible. Because when you go in to get a routine mammogram, like every year, you don't know if you've got a cancer in there or not. That's why you're going in there to get the mammogram. You're thinking, I might have a cancer. And I'm thinking, if you do have a cancer, the last thing you want to do is squish it. So don't do that. Let's do an MRI. Let's do some of these very high attenuating ultrasound examinations. Let's do a physical examination or just biopsy the son of a gun without a mammogram. But why take a tumor and squish it? It's just stupid.
So somebody might have just heard this and they may be thinking to themselves, okay, I don't want to squish my breast because it might spread a disease that's there. But won't getting a biopsy, if I poke it, isn't that going to spread the disease? I've heard
I did some research on this, I want to say 6-7 years ago. And at that time, there was no hard data to insinuate that biopsies actually spread cancer. I suppose it's possible. It kind of makes sense theoretically, but people should know that at this point, a biopsy, sometimes you need a biopsy sometimes. And you got to weigh. In medicine, we do things like that. We weigh what's the possible risk against the benefit. And there are going to be times when the potential of a risk of a biopsy, which is not just so much metastases, it could also be infection, could be bleeding. There's other things you can get from a biopsy. I tend to avoid biopsies when I can, but a lot of the times you actually need the biopsy to know what the heck you're doing.
I'm going back and forth with these parallels with males with prostate disease and now women with breast disease, because with the males, let's remove the prostate. Sometimes with the breasts, are like, well, let's just remove the breast. Let's have a mastectomy. So let's do that. And sometimes let's just do a double mastectomy. The other breast doesn't have it, but let's do preventative and let's remove the breasts. What is your thought on that as far as long-term positive results, I guess, coming out of that?
Yeah, if you were either a patient with breast cancer or with prostate cancer and you came to see me And through my examinations, I was able to determine that that could be surgically removed. I would probably recommend that. Now, what I would do prior to the surgical removal is I would give you 3 weeks of what we call preconditioning treatment. I would upregulate your immune system. I would upregulate your vitamins. I would change your diet. In other words, I would get you ready for the surgery. And by doing that, it's a 3-week protocol. But by doing that, when you go through the surgery, you're going to get out of the anesthesia much more quickly. You're going to limit the chances of any kind of surgical, problem that may or may not develop from that surgery. But yeah, I'm all into surgery. If you can get a cancer out with surgery, let's do it.
Okay. All right. So we got a solid tumor. We can remove it, do it, but let's prepare the body for that surgery for a few weeks for optimal healing. Okay. I got it. Going back to the topic of IPT, insulin potentiated therapy, the volume of chemo, the dosage, is it the same as conventional? Is it less? What is the difference there? And how frequently do you give this to a patient, at least in your practice?
Yeah, so it's all individual from patient to patient, but typically speaking, since we're getting more of the chemo into the cancer cells, we don't have to give as much of the chemo. And typically that's around 1/8 to 1/10 the dose. So an example, if I'm going to give a patient, if they said the conventional management it requires say a dose of doxorubicin of say 80 milligrams, I'm going to give like 8 milligrams. I might give 15 milligrams, but I'm not going to give nowhere near up to the 80.
Got it. And is this something that the patient would receive once a week or more than once a week?
Yeah, so typically we do it twice a week.
Okay.
So there are going to be some patients where we do it once a week. There are going to be some patients where we do it once a week or twice a week for 3 weeks, and then we go to once a week, and it can vary a lot depending on response to therapy and other aspects.
Does this way of delivering a chemotherapy, does it reduce the side effects, the negative side effects that a patient?
Hugely. To give the audience an example of this, one of my nurses that's in my clinic now, who is absolutely excellent, as all of my nurses are, by the way, at the same time has worked in a conventional oncology infusion center. And he has told me unequivocally, you go into that infusion center, you're going to see some miserable wretches sitting around getting treated. You come to my infusion center, you're going to see people sitting around, jawing, laughing, talking, sharing stories, getting their treatment, going out and playing golf.
Okay. That's good.
That's not to say that we don't have to deal with nausea sometimes. We do, or diarrhea or something like that. But it's nothing like what you would get with strictly conventional therapy.
I have to let you know, I don't think you know this, but now I'm almost positive you don't. But many, many years ago now, I saw you do a presentation on melatonin for cancer patients. As a result, I became a melatonin consumer, a high dose melatonin consumer. And I have read the literature that you had discussed at that time because I was fascinated. Let our audience know why you use melatonin with a patient with cancer and what are the benefits for the patient, the big ones anyway, that they're going to receive from that.
About, I want to say 12 years ago, I ran into a fellow, I'm surfing the internet. That's what I do. I'm surfing the internet for things new about medicine. And this paper pops up. And it says high doses of melatonin prevent cancer. And I thought, what? Okay, I thought melatonin was for sleep. So I'm plugging into this study, and it's a mouse study. And what they did is they took a bunch of mice that were programmed genetically to get breast cancer, and they divided them into 2 groups. In one group, they gave very high doses of melatonin to, and they never got the cancer. And I thought to myself, oh my goodness, wow, Now, I know mice are different from people, but still, that's pretty convincing. So I called up the lead author on that, and he talked to me for about like 90 minutes, 2 hours. Okay. And turns out that this man is he's a professor of animal experimentation at the University of Texas at Austin. He's only authored about like 4,000 papers on melatonin. One of the leading experts, if not the leading expert on the use of melatonin in the world. And boy, he told me some stuff. And now he only does animal experimentation, okay? But in these animals, it's astounding how well melatonin can work to prevent cancer and treat cancer as well, but in very high doses. So then I asked him, well, very high doses, isn't there going to be a problem with that? And he says, nope, not a problem. We cannot find a toxic dose of melatonin. We've tried for years. We give them gigantic levels that would surprise you, and there's no toxicity. We can't find it. So that's thing number one. Thing number two is you don't suppress your own production of melatonin even with these high doses. And thing number three is, and the thing that's really earth-shattering to me is, we hear in the literature, and I always thought that sort of the amount of melatonin that the body makes is in the order of like 0.5 milligram to 1 milligram, okay? That's true for the brain, but every other cell in the body, with a few exceptions, produces melatonin too. So when you add up the total melatonin production in the body, most of which is in the intestines, by the way, you find out that most of us are going to be producing 500 milligrams of melatonin per day in the body. 1 milligram in the brain, but 4 to 500 milligrams in the body. And so that got me going. I started using these rather large doses, and by that, the listeners can understand we're looking at 1,000 milligrams. By the way, the other thing that I learned about the melatonin was it doesn't put you to sleep. What puts you to sleep is dark exposure. And then your pineal gland does what it does, and that's what puts you to sleep. But the melatonin sensitizes you to the darkness. So if you take a dose of melatonin and it's nighttime, it makes you sleepy. If you take a dose of melatonin in the day, it doesn't make you sleepy, with a few exceptions. I have seen this happen with a few exceptions. So with my more serious type patient cases, I have them taking melatonin all day long and right before they go to bed. Very high doses, 0 side effects, and much better responses across the board to all the other. It's just one of the many things that we're going to do, but it's a big thing as far as I'm concerned.
Yeah, I'm an advocate of it, and to your credit, that's where I first found out about it years ago, and I went down the melatonin rabbit trail looking for the literature. So I thank you for that. What are some of the other adjunctive therapies that you're using with the patients that are receiving IPT that they might be experiencing every week, day in and day out while they're there with you?
Yes. So one of the therapies that can be super effective is the high dose vitamin C. So now, especially oxidized vitamin C. Now that might be a little weird for people to hear, but oxidized vitamin C is what it goes by the name dehydroascorbate. Dehydroascorbate gets into cancer cells through a different receptor site than regular vitamin C does. And because of that, you can get a lot more dehydroascorbate into a cancer cell. So when it gets into the cancer cell, it is immediately converted back into regular ascorbate. So one of the tricks that we do is we'll hang a bag with some vitamin C in it, and there'll be a lot, maybe 100 grams, maybe 200 grams. And then we'll shoot some ozone in that. Ozone's an oxidizing agent. So we'll oxidize all that vitamin C. And that's a lot more effective than just plain vitamin C. And we'll run that in, and we'll do that on the days that they're not getting the chemo. And So that's one of the things that I find really valuable. We'll do that once or twice a week. The other thing is that we're constantly doing detoxification, and that would be with saunas. We use some pulse magnetic electro frequencies to help detox. We use a lot of ozone therapy, intravenous ozone therapy. And by the way, you can, a lot of other things you can do with ozone directly into a tumor. So ozone will kill a tumor cell, period, 100%. There's no tumor cell out there on this planet that when exposed to ozone gas will not die. One of the great things that we were able to do is treat bladder cancers. Why can we treat bladder cancer so effectively? Because you can get the gas right on the cancer. We put a catheter into the bladder, shoot the gas into the bladder. That gas is right on the cancer, bang, kills it. Now it's going to kill it in portions, so just you're not one and done. You might have to do this for a regular basis until you get the whole cancer out. But I'm literally at this point 100% success rate on bladder cancers, even those that puncture through the wall. I can still get 100% success rate. And by that I mean the urologist looks in there with a cystoscopy, sees the cancer, and 3 months later, he looks in there, he doesn't see anything.
Wow.
And he scratches his head and said, I don't know what's going on here. This is weird. You had cancer before. I got a biopsy and everything. Now you don't have it. I can't believe this is happening. So, and actually neither could I initially. So I said, okay, get another cystoscopy in another 3 months. So you get another cystoscopy, still no cancer. Bingo. So, so we use a lot of ozone. The ozone goes into the blood. We do ozone saunas. We do a lot of ozone colonics because that's very detoxifying. The idea with the chemo is, even though I'm using smaller amounts of chemo, it's still a toxic drug and it can accumulate, especially the platinum drugs. And when they accumulate, that can be a problem. So what we do is we put in the chemo, then the next day we take it out, or at least as much of it as out as we can, get it out of the dang body. It's already done its thing. It's already killed whatever cancer cells it can kill. So let's get it out of the body so it doesn't accumulate. And ozone colonics are really good at doing that.
So a new patient that enrolls with your practice they have a cancer diagnosis, how long should they expect to be there for? Is this somewhere they're going to be there 2 weeks, 3? Is it 12 weeks? What is it? They call around these places, right? Wanting to know how long do I need to go for? What does that look like with your practice?
Yeah, it's a judgment call, of course. A minimum 3 weeks. That would be a minimum.
Mm-hmm.
And that's usually when they have like say classic case would be a breast cancer. They go in and they remove the tumor, and they either don't have good margins, or they had one of the sentinel nodes was positive, indicating that there may be some cancer residual in the body. So at that point, we'll do 3 weeks of this program I just mentioned, of that treatment, and to make sure they don't get a recurrence. And on that, by the way, I'm 100%. So that's a 3 weeks, pretty much standardized protocol that we adhere to. For other patients, I might need to have you in there for 6 weeks, 8 weeks. All sorts. It depends on how are you responding, how well are you doing the stuff I asked you to do, like the diet and the stress management and so forth and so on. And of course, what's your cancer like? Because they're all different. The patient's different. The cancer's different. So if I've got 2 patients with the exact same cancer cell type, let's just say a breast cancer, the treatment will be probably different in both those people.
Okay, got it. That's very helpful. Now, when a patient contacts you, because someone's going to see this and go, I'm going to contact, Dr. Shallenberger's practice. Is it a consultation you set up first by telephone? Is it a Zoom? Do you make them come in person? Because someone's going to see this that's outside the state of Nevada. Like, it'll happen. What does that look like?
Yeah, a lot of my patients do come from around the country. That's true. If they're local, obviously I want to see them.
Mhm.
Now, if they live in, across the country in another area, the first thing to do is let's talk. So we'll talk about what the cost would be. We'd talk about what I require of them. We can get into diet. We can get into, talk a little bit about the actual therapy and maybe the actual drugs we'll use, and talk about the testing, which we haven't really talked about. So maybe we talk a little bit about that.
Yeah, yeah.
And just give them an idea. Okay,
Mm-hmm.
this is what I got to commit to. I gotta go out there for 6 weeks.
Mm-hmm.
I got to commit to this much money. I
Mm-hmm.
got to commit to doing this kind of a diet, et cetera, et cetera. And we can have that kind of conversation just over the phone to see if we're a good match.
When it comes to testing, so what type of testing do you like to have done before somebody becomes an official patient or during that process? And then what type of long-term testing should a patient with cancer have for reassurances, right?
Yeah.
And for how long? Is that 5 years, 10 years? Assuming that, we're going out that far now, but talk to us about testing because cancer patients in the what I would call the integrative marketplace or the alternative marketplace, they're being marketed a lot of different tests now. There's a bunch of them.
Yeah.
What tests do you like and why?
The initial tests are going to be things in the order of scans. A really good marker is often pain or other symptoms caused by the presence of the cancer. So, as we're going along, we want to see that pain go away. We want to see those symptoms go away. And then specific testing, I like to use the RGCC system, which basically what we do, it's called a liquid biopsy. That's sort of the technical cost of technical description of that. Basically, we get a blood sample. And in your blood, by the way, if you have cancer, some of your cancer cells are in your blood, 100%. Okay, so these guys are able to find at this particular laboratory, and then, by the way, they often call it the Greek lab because they're located in Athens. But so we send the blood back to those guys. They are able to isolate the cancer cells out. They grow the cancer cells on culture plates, and then they do two really fascinating things. They send me back a report on two things. One thing is going to be all the genetic markers on the cancer cells. Now, those genetic markers are going to help me to determine what herbs and nutrients are going to be most suited for that particular cancer. The other thing they do is they'll take the cancer cell and expose the cancer cells to various chemotherapy agents. And they'll tell me, okay, this chemotherapy agent over here only killed 30% of the cancers. This guy over here killed 70. This guy over here killed 90. Which one do you want to use? Well, it's pretty obvious. I'm going to go with the 90. Because without that kind of direction, we're down to guesswork. Now, we're pretty good at guesswork, but that helps. I like that information to be in there too. I know that certain kind of cancers respond really well to, say, a platinum drug. And it's just comforting for me to see that the RGCC test comes back and says, yeah, it responds really well to a platinum. Because sometimes I'm thinking there should be a platinum here. And the RGCC comes back and says, platins don't work so good. You're going to go to this drug over here that you would not have thought of. So it gives me a good option. That's how I determine how to go about it, by the genetic markers and by the chemosensitivity testing. But then the other thing is the follow-up testing. So that obviously can be scans, but one of the other things it can be is what they call cancer markers. That refers to the fact that certain cancers secrete into the bloodstream certain molecules that we can measure. So if your cancer happens to do that, an example would be a PSA. So your cancer's making PSA. So we can check the PSA periodically. Like I said, I either want to see it go down or stay the same at the very least. Another common marker, for example, for say ovarian cancer would be a molecule called CA125. But we can get those markers and we can monitor them over time. Another one I like a lot is called the Signatura test. And the Signatura test is where we get the DNA of the cancer. Now, you can actually get that from, if they've had a biopsy, you can get it from their biopsy. And then you get the DNA. It's on there. So even if it's just a slide, it's okay. I don't need I get the DNA off that slide, send it to this lab called Signatura. They will identify the DNA that's specific to your cancer cell. Now, why that's cool is because a year later, 2 years later, 3 years later, we can analyze your blood for that DNA. If we don't find it 2-3 years later, that's a pretty good sign. On the other hand, if we see that the DNA levels in your blood are starting to go up over time, that's our indication that no, we haven't done our job fully. We need to be jumping on this.
On the scans, MRIs, PET scans, what type of scans are you in favor of? And some patients out there, they get spooked out about PET scans.
Well, I would too. And they're grossly overused by my colleagues. I mean, they'll do a PET CT every 3 months for like 5 years, which is absolutely nonsense. That's crazy. Number one, because of the radiation. And number two, because you don't need to do it that often. You do need to do it, but not that often. But here's the thing. And we're back to melatonin again. So in 1998, the U.S. Army said, well, what are we going to do to protect our soldiers if they get around a lot of ionizing radiation? And so what they did is they took white blood cells from the soldiers and exposed them to various levels of ionizing radiation until they found out a dose of ionizing radiation that causes mutation in the white blood cells. And then they went and they gave the soldiers a whole bunch of different things, different drugs, different nutritional substances, whatever. And they repeated the experiment. And they were looking to find out, well, what can we give them that attenuated the mutation development at this certain dose of radiation. And what led the list was melatonin. So based upon that study and the details on that study, we have learned that if I give you 300 milligrams of melatonin 2 hours before your CT PET, I'm going to obliterate most of the accumulated ionizing radiation. So that's what we do. We tend not to want to use those scans too often. We do use them because you need them. But when we do use them, we're going to give that melatonin. And by the way, the second one below melatonin that was good at this was something called tocotrienol, which is a version of vitamin E. Mm-hmm. So yeah, 2 hours before you go get a PET CT, if you're in my world, you're going to get a big old dose of melatonin and tocotrienol to obviate the accumulated ionizing radiation.
I'm curious, how much tocotrienol?
That'd be 450 milligrams.
Yeah.
Not that much, but.
No, it's not that much, yeah. But you just mentioned two things that I consume, so.
Well, you gotta know we gotta prevent cancer too.
Yeah, that's the deal. You've been in this field for a long time, and you've been very generous with your time, and I want to bring it to a close. But if you don't mind me asking, how young are you?
Yeah, so I'm working on 79 now.
Okay.
79 years old.
How tall are you, and what do you weigh?
I'm used to be, in the old days, 6'2.5". Now I've settled down a little bit, and I'm 6'2", and I'm 174.
Okay, I'm asking you that because it looks like, well, you practice what you preach, right? And I've talked to some patients, and they're not sold on certain doctors because like, this doctor doesn't look healthy to me. So they get turned off by it, right? But obviously, you look like you practice what you preach. What does your lifestyle look like as a whole, as a doctor? Like obviously it's not by accident that you're at that body weight, you look this way, you got vitality, etc. You're still practicing, you're still doing this. What is your lifestyle like?
I learned long ago, decades ago, and I developed this motto. And the motto was, the best cure for any disease is not to get it. That's the best cure. Don't wait till you get a darn disease. So I went on a search decades ago. How can I prevent a disease in an individual? And so we learned about things called VO2 analysis, VCO2 analysis, and we learned how to do various tests to look at your levels of certain nutrients, your levels of omega-3s and omega-6s. So what I really enjoy doing is, besides helping cancer patients live a better life, what I really enjoy doing is seeing people such as you, for example, who don't have anything wrong with them, and evaluating that person and trying to find, well, what's off? Is your circulation off? Is your mitochondria off? What is nothing off? Because if there's something off, let's fix it now while you're healthy. And then I'll see somebody like that maybe once every 2 years. And we'll just tweak things as they get older, because I got two jobs when I see a patient. One job is to help them with the problem they have at that moment. That's obvious. The other job is not so obvious, is I want to help them with a problem that they may get 5 and 10 years from now. That's my job. I have to think of that. What's your family history? What's your genetics? What's your lifestyle like? Okay. Oh, these tests and all those things add up to, you're at a high risk for such and such a problem. So let's anticipate that. Let's deal with that and check that box so that you don't end up with that problem. So with that in mind, I've done the same thing to myself. I got to be a good example to my patients. If I come down with cancer, which I don't plan to, but there's no guarantee. But I'm certainly going to do every one of those tests on myself. And I'm going to be on myself about my diet. And if I see that wonderful piece of chocolate cake over there, and odds are pretty good I'm not going to touch it, not because I don't want it, but I expect myself to do everything that I ask my patients to do.
Right. No, it's great. That's great. That's great advice, and thank you for following your own advice, because it does encourage those that are coming to you. Last question I'm going to ask you. This is a question that we ask our guests, and the question comes from the last guest that we had. So the last guest that we had is asking the question of the next guest. So here's the question, Doctor. If there's anything that you wish you would have learned sooner, that altered the way that you practice medicine sooner, what is that thing? If there's anything that you could have learned sooner that would have altered your practice sooner, obviously for the better, what would that have been?
First thing comes to mind is stress. Stress. Now, here's the deal. In science, what doesn't get measured doesn't get attended to. The example I would use is, say, blood sugar or blood pressure. If I don't monitor your blood sugar, I don't know what's going on with your blood sugar. If I don't monitor your blood pressure, you could have way high blood pressure and I wouldn't know it. Or you could have perfect blood pressure. I wouldn't know it. So what doesn't get measured doesn't get attended to, folks. Okay? Guess what doesn't get measured in medicine? That's huge, is stress. If you look at studies, many published studies of both autoimmune diseases and cancer, you will find unquestionably a 85-90% of the time, you look at that patient, why did you get this problem? It's at a period of intense stress. But here's the deal. We don't have a way to measure stress, so it gets ignored. So what we do is, even though I still don't have a way to measure stress, I pay attention to it with the way I didn't used to. So 20, 30 years ago, if you came to see me and you had stage 4 cancer, obviously you got stress. But I wanted to know right now, but I wouldn't know what to do with it. Now we have systems to deal with the stress, neurofeedback systems specifically, but we have systems to deal with the stress. And that's part of this whole deal. And attitude. What's your attitude like with this disease? You better have the right attitude. What we know from Brenda Stockdale's work is that an attitude of anger towards cancer is a very helpful attitude. An attitude of fear is a very unhelpful attitude. So if you've got cancer out there and you're upset about it and angry at it, good for you. But if you're fearful, if your oncologist is telling you you're going to die, there's very little we can do. You have that. That's going to negatively affect the actual outcome of the cancer. So first thing comes to my mind is, I'm now paying a lot more attention to stress and working with my patients more along that angle than I ever did before.
Dr. Shallenberger, thank you so much for joining us today. We really appreciate it. And one more time, if you're watching this out there, you want to contact Dr. Shallenberger's practice. That's the Nevada Center for Alternative Anti-Aging and Medicine in Carson City, Nevada. They're at 775-884-3990. And their web address is antiagingmedicine.com. Thanks again, Dr. Shallenberger. We really appreciate it.
Thanks, Robert. Great interview. Appreciate it.
All right.